So next we have Dr. Aparna KS. She will be speaking on Eviseration, how to do it right. I welcome you, Dr. Aparna. She's a consultant in Chaitanya Eye Hospital, Trivandrum.
Good morning. I'll be discussing the right way of doing an evisceration. Evisceration is a surgical procedure of removing all the intraocular contents, preserving the remaining scleral shell, extraocular muscle attachments, and the surrounding adnexa. Usually it is followed by placement of an orbital implant to restore the orbital volume. Even though it is a radical procedure, our aim is to provide maximum cosmesis for the patient and to maintain a healthy socket. Evisceration was first described by James Barr in the year 1817 as a technique for a complicated cataract surgery with expulsive choroidal hemorrhage. In 1874, Noyes introduced this technique to treat intraocular infections. And in 1884, Mules described the first placement of an orbital implant that was a hollow sphere. Various indications for evisceration are infections like endophthalmitis, panophthalmitis, phthisis bulbi, anterior staphyloma, various causes of painful blind eye such as an end-stage glaucoma. Intraocular malignancy is an absolute contraindication for evisceration, and relative contraindications are severe phthisis bulbi and microphthalmia. Before starting the procedure, always make sure that the informed consent must be signed by the patient as well as by the bystander, explaining the nil visual prognosis of the condition in their own mother tongue. And always take a B scan for diagnosis, then for documentation, and to rule out any intraocular malignancy. These are the set of instruments required for this procedure. We can do it under general anesthesia, IV sedation, or a regional block. I prefer to do it under retrobulbar block using lignocaine with adrenaline. Then all the other instruments are routine for various forceps and scissors. And only special instrument required for this procedure is an evisceration scope. Then after removing all the contents, we will place an implant, then close in layers. About the basic steps of evisceration, first one is a peritomy, that is we have to perform a 360-degree peritomy and a 360-degree keratectomy to remove the corneal button, then scoop out all the intraocular contents. Then next step is a sclerotomy that I will be discussing later. Then placing the implant and close in layers. So over the years, various techniques of sclerotomies has been evolved, and the basic purpose of a sclerotomy is to place a larger implant and to give a scleral cover to prevent extrusion. The basic step is in all sclerotomy technique is cutting either a relaxing radial scleral incision or an equatorial scleral incision with or without optic nerve disinsertion. Today I will be discussing the 4-petal technique, which was described by Salesans and Sands-Lupus in the year 2007. Here we will make 4 incisions in between the attachment of the rectus muscle, starting from the limbal end of the sclera, extending to the posterior aspect where the optic nerve is attached to the sclera, then disinserting the sclera. And so we will get 4 petals of sclera, and each petal is attached only to the corresponding extraocular muscle, so that we can place a larger implant in the intracorneal space, and the opposite scleral petals are closed in a double breasting manner. So I'll be showing a video of evisceration that I have done in a 71-year-old male who underwent multiple intraocular surgeries, then a failed corneal graft with a sloughed graft. The eye is very much inflamed, so it is very bloody feel, and the conjunctiva is very much attached to the underlying tissues. So I am straightly going into the keratectomy step. Here I am making the stab incision with the number 11 blade, then extending it 360 degree with the corneal scissors. After completing it 360 degree, we have to remove the corneal button. Next step is removing all the intraocular contents. So always make sure that we have removed all the scleral remnants, because even if a bit of uveal remnants, even if a small bit of uveal tissue is remaining, that can produce profuse bleeding during the postoperative period. Then we have to clean the scleral shell with absolute alcohol. Then irrigate the scleral shell. Then I'm trying to separate the conjunctiva. It is very much adherent, it is causing bleeding. While making sclerotomies, try to avoid the conjunctiva along with it. Then making the scleral petals, starting from the limbal end, extending to the attachment of the optic nerve. Then finally, we have to disinsert the optic nerve so that we will get 4 petals. And for each petal there will be only one attachment, that is the corresponding extraocular muscle. Then the anterior and the posterior end of the petal is free. So these are the 4 petals with anterior and posterior ends are free. So this allows placement of a larger implant so that I could place a 20 mm PMMA implant easily. Next is the closure of the sclera. That opposite scleral petals are closed with 60 vicryl interrupted sutures in a double breasting manner. Here the opposite petals are attached. And after that we have to suture the anterior tenons. Then close the conjunctiva. So we will get multiple layered closure of the implant that will prevent an extrusion. Here anterior tenons is sutured with a 60 vicryl interrupted sutures. Then conjunctiva is closed with continuous key pattern sutures. And at the end of the procedure, we have to place a conformer in order to prevent the contraction, and to retain the conformer for at least 1 week. We have to do a tarsorrhaphy. So advantage of this 4 petal technique is it allows placement of a larger implant, and the double breasting of the scleral petals allows that will prevent the extrusion of the implant. Complications of the procedure are retrobulbar hemorrhage, orbital edema, dissemination of unexpected intraocular tumors, implant exposure, implant extrusion. Then at the end of 6 weeks, we placed a custom fit prosthesis for the patient, and this is the final appearance. Thank you.
Excellent presentation. Just 2 things, like when you were telling that you were not able to dissect the conjunctiva and tenons. One thing is if it's inflamed, brimonidine help as a topical eye drops. The second thing is you should inject lignocaine and adrenaline, injection in the subconjunctival space. One, it gives you a hemostasis, and it also separates the conjunctiva and tenons. Why is it important? I never compromise on the surface,
yes,
right? Yeah. So it's important to take the conjunctiva separate and the tenon separate in order to avoid inadvertent implant exposure. So these are the modifications that you can do whenever there is an inflamed socket, as you had in this. Now regarding the 4 petal, I can take opinion from the other oculoplastic surgeons here. I used to do 4 petal when I started, and I was excited about it. But then later I have been seeing the displacement, migration of the implant through the 4 petals. So now I totally stopped 4 petal. This is purely my experience.
I'm doing equatorial also, equatorial sclerotomy also.
Right. So what I just do is like 2. When I have to keep a larger implant. So it's more safer and more confined into 2 petals of a sclera. Sometimes when you do a 4 petal and it's not sutured well, the implant can migrate either supratemporal, infratemporal, or any of the quadrants. Yes, so I have personally stopped doing 4 petals. We can take opinion